Okay, welcome. If you're joining us, this is the maiden voyage of the Association for Precision Pharmacy Services webcast. Today, we are happy to present Dr. Blair Thielemeir, who is the founder of the Pharmapreneur Academy. And our discussion today will be about business models for consulting pharmacy and pharmacists. And without further ado, I'm going to pass it over to Dr. Thielemeir.
Hi, everyone. I am Dr. Blair Thielemeir, and I am excited to present to you today some options for pharmacy consulting. So first, I want to talk a bit about why there's so much interest in pharmacy consulting today. For me, I was drawn to the flexible schedule and the increase in job satisfaction. In addition, I did feel like there was somewhat of a glass ceiling in my current role as a clinical pharmacist. So, looking into pharmacy consulting, I really felt called to the entrepreneurial side of it, uh, figuring out how I could build a business that was based on the things that I really loved about pharmacy meant a lot to me and my career. So I want to ask you, what is it that you love about pharmacy? So perhaps it's working one-on-one with the patients and making recommendations, or maybe it was you had a role model in pharmacy and that's why you were called to it. Or even you have a family member who is in the healthcare field. So my mother is a nurse practitioner, and I always known that I wanted to be in the healthcare field, but I knew I didn't want to be in the position of a doctor or a nurse. So pharmacy was such a good fit for me from the science side and the understanding of how the medications were functioning. The piece that I felt like was missing was that patient care piece. So a little bit about my story. I had been working as a clinical hospital pharmacist for about 3 years after graduation. We had the new house, the new car, traveling around the world, that kind of thing. And I was taking it a bit for granted until April 2014, I lost my job and benefits as a full-time pharmacist. I happened to be about 6 months pregnant at the time. So thankfully, I was able to get on my husband's insurance, but it really led me to reevaluate what is it that I want from my pharmacy career and what is it that I want to do. I did feel like there was a bit of a glass ceiling in retail and hospital, and there wasn't much flexibility for me in terms of being able to leave if my daughter had gotten sick or something happened with my family. So I also looked into management, and I actually applied for a director of pharmacy position as at a local hospital. What I figured out very quickly in that management application process was there was a lot of added responsibilities and a lot of extra work, but the salary wasn't really keeping up with that pace of adding in more responsibility. So again, I was really intrigued by the idea of entrepreneurship and having my own business. So that year, my maternity leave was really what gave me a chance to reflect on what I wanted. So that year, I had already taken about a $40,000 pay cut, and we had survived. So I really didn't want to go back to the golden handcuffs. And if you're not familiar with that term, that's basically where your lifestyle gets so expensive that you're forced to stay in a higher paying job. So luckily, my job loss had kind of handled that for us, but I was already very wary of going back to a single income stream. So what I thought was I don't want to put all my eggs in one basket, and I really want to diversify this income. So I was confused at this point, of course, by my career direction. And being 6 months pregnant, it's not quite the best time to go out and be job hunting. They expect you to work for 2 months and then you're going on a 2-month vacation pretty much. So at this point, I hadn't done a lot in terms of networking or building a personal brand or using LinkedIn or anything. But what I had done was making local connections. So I reached out to several of the local community pharmacy owners here in my area and asked if they needed any help doing relief. So that's what I started doing, and I really enjoyed it. It fit my personality, and I was able to grow quite a good reputation as a floating pharmacist. Some other things, that I've heard that pharmacists that I work with in the Pharmapreneur Academy are being more and more concerned about is the threats to the job market. So other pharmacists are seeing this writing on the wall that's leading us to feel the need to accumulate more advanced degrees. There may be having difficulty finding work and finding the job market very competitive. And unfortunately, as the job market is shrinking, technology is also growing exponentially. So in the next 10 years, technology has the potential to completely change our lives and our work. This is a report that shows occupations that are susceptible to automations currently. So this is not even with the advent of AI technologies. And pharmacies over here in this green circle at about a 47% automation potential. So the higher you go up on the y-axis, the higher the automation potential, and the further you go on the x-axis, the higher the hourly wage and benefits. So there's a couple of ways that you could look at this. You could see this as a threat or as an opportunity. So myself, I've always been intrigued by entrepreneurship and innovation and technology. So I'm definitely not trying to be a Debbie Downer here. I just want to highlight that the healthcare industry in general is ripe for disruption. And if you are focusing on how you can be growing and adapting as a pharmacist, you can get ahead of this curve. So my question is, will you see this change as a threat or an opportunity? So the threat mindset really says technology is taking over my job and it's a bad thing. But the opportunity mindset says technology is taking over my job so that I can do other things and add new opportunities and offer even better patient care. So today, Noah and I want to provide you with some tips how to identify and attract those new opportunities. So the opportunities we're going to be discussing today is pharmacy consulting. So now I am a community pharmacy MTM consultant. And as I mentioned, after I lost my job, I was kind of toying with the idea of entrepreneurship and working relief at a bunch of local independent community pharmacies. So one opportunity came my way that I had actually turned down a few years before. He had asked me to take over all of their MTM cases. And at this point, I still felt that I didn't know anything about MTM. I didn't know how to use the platforms. I was afraid of billing Medicare. It was just very confusing for me to use them. But I had a friend walk me through the first few cases. And after a few months of meeting with the patients and offering them MTM services, I fell in love with it. And I felt that MTM was the patient contact that I was craving, but it also gave me the challenge that I was needing. So this is the first option for consulting that we're going to talk about today, which is the community pharmacy MTM consultant. So this person would manage the MTM program for a pharmacy where they are an employee. Most times this is done through the main MTM platforms that the pharmacy is contracted with. This person will help improve quality measures, which we know as star ratings, for the pharmacy, and by helping them implement new programs such as medication synchronization and point-of-care testing services. This person is also responsible for going out and developing relationships with prescribers and leveraging those relationships into collaborative practice agreements. The second option for consulting is as a primary care consultant. This person is going to work in a physician's office to focus on the quality measures of that office. So physicians have quality measures they're being graded on as well. And they'll focus on those, focusing on the most complex chronic patients that these providers are seeing. Many times these are done through providing incident to services in the physician's offices. So this person is going to be responsible for working with the most complex patients, the patients that are responsible for about 50% of the healthcare dollars spent. They're also going to help the clinic implement new programs kind of as a clinical coordinator. So those programs could include chronic care management, transitional care management, annual wellness visits, and pharmacogenomic testing. They can also handle such services that bridges the gap between the community pharmacy and the primary care physician or provider, such as adherence services, refill requests, and prior authorization requests. This person most likely works under a collaborative practice agreement. And the next option for consulting, Noah's going to talk a little bit about.
Yeah, thanks, Blair. So obviously, and this is to dovetail what the Pharmapreneur Academy has already been teaching people, is there's a variety of ways that you can build out a practice that supports the prescribing physician. In our mindset here at the association is that, you know, there's probably no way for you to only be paid through direct contracts with the insurance providers, but what we've developed is the system that every prescribing physician or any essentially medical provider uses in order to gain access to reimbursement dollars associated with their specialty. So we call that the 3 C's at this point. There might be 4 C's at some point in time, but the first one is really simple. It's credentialing. We utilize the CAQH system, which is open to any provider. It's just it can be a little difficult to manage, but what it does is it establishes your clinical credentials outside of being tied to a pharmacy. So it defines you as not just a not the person who's behind a counter filling pills, but the clinician who can see a patient and intervene in their care. Now, obviously, you're not prescribing, and CAQH is not supposed to be a system that essentially allows you to define yourself as something you're not. What it does is it tells the payer that you are a clinical pharmacist who can bill against certain codes. Those codes are fairly common. Everybody's heard about them over the last few years, the MTM codes, which are specific to a pharmacist. And the CAQH profile, when submitted to a payer, is meant to generate a contract. That contract, which is the second C, is a cutout against those specific reimbursements. In order to get that and have it make any sense to you, what we also integrated was a coding course, which essentially teaches you the basics of medical coding, or I would say just beyond the basics of medical coding, as specific to you, the pharmacist. So how do I fill out the HCFA 1500 form or utilize an e-billing solution when I'm billing under my own NPI with my own taxonomy? As Blair mentioned, if you're doing it under a collaborative agreement, you're billing under your own NPI, but you're utilizing the prescribing physician as the Medicare provider number, or their practice as the taxonomy. What we've developed is systems by which you don't always have to do that. You can establish yourself as a practice. You can get a contract under your taxonomy, and you can start billing, as your specialty, in order to get reimbursed directly. Now, this is all, it's very new, but it's not, it is no different than the way that every other medical provider gets paid. So CAQH is very simple. If you look at it, it is the phase 4 of the Affordable Care Act, which, regardless of where that ends up, there's no going back to paper. And what CAQH has done is has come up with ProView, which is the digital transmission of your credentials to secure a contract. And it can be a little cumbersome. We have a guide that walks you through how to set it up, optimized for a pharmacist, and utilize it to submit contract applications. Next, we move on to contracting. The contracting portion of this gets a lot easier when you use CAQH. In this case, we have an ongoing project with a company called MagnaCare up in New York. And MagnaCare sends you an application. If you are a CAQH provider, which as is highlighted here, all you need to do is put in your number and then obviously fill out your tax ID information for, and obviously DEA waiver if applicable. So it simplifies what usually is a 17 to 25 page application process, and only requires that you fill in that one number, which once you have it, this is the same application that could go out to a Cigna, Aetna, Humana. That doesn't mean that if you're doing these applications yourself, you aren't going to see denials just like every other provider sees denials. It just means that you have a way to submit for the contract. We also provide the resources for denial responses and resubmissions. And last but not least, we have coding. The coding portion of this is fairly important because obviously the change that we're trying to affect in the industry is how you get paid directly. The MTM codes are specific to you as a pharmacist. That means nobody else can really bill these. What does that mean? That means that if you're able to see a patient according to the MTM criteria, then you're getting paid on a time-based billing model. These are time-based codes. 99605 is the first 15 minutes of your initial encounter. 99607 is the first 15 minutes. I'm sorry, 99606 is the first 15 minutes of an existing patient encounter. After that, you've got increments of 15 minutes that are the 99607 code. The way that works out is against a max allowable on a patient, which for CMS, they've determined that the max allowable for a medication therapy management eligible patient for 2017 is $3,719. That sounds like a lot. Obviously, that means you've spent a lot of time talking to a patient. It's similar to the physical therapy codes, whereby once you exceed the max allowable, that patient is no longer going to pay, or their plan will no longer pay. Private insurance is really, no different than Medicare in this regard as well. So what we're encouraging our membership to do is pursue patients who are not going to require you to need a PTAN, and then you can balance out a practice similar to what the Pharmapreneur Academy advocates in a collaborative agreement incident to model plus a direct billing model, whereby you've got kind of a blended value of a patient base that is not only the highest risk elderly patient. So our goal is to push the envelope on how far a pharmacist can go in getting reimbursed directly. This is a sample EOB. Basically, it shows that for 2 hours worth of work, the pharmacist was compensated directly at $220. And it's actually interesting because there is a bit of a discrepancy. The 99607 code could have paid more. And again, when you bill, this is one of the things you learn. You get paid the max or whatever it is under the max that you billed for. If you didn't know, they don't help you reconcile that. So, but in this case, obviously, it's 120 minutes worth of work, and then that is a patient that you're hoping to maintain a long-term relationship with. So, it's a new and exciting path for the independent clinical pharmacist or the pharmacy that's trying to branch out and develop better relationships with their patients in the community. With that, this is just a basic eligibility. This is across the boards. If you're Medicare or private insurance, these are the eligible patients for medication therapy management. Our focus is to actually encourage the payer community to develop the written protocol for reimbursing for medication therapy management. And that's what we've done with MagnaCare, and we're in the process of doing that with other payers nationally. So it's very exciting.
Absolutely. And as I mentioned, the consultant pharmacist really can focus on these patients who are more complex. They, have 2 or more chronic conditions or on 6 or more medications. And this just gives you an idea of how many patients are actually eligible for these services. So it's really exciting what pharmacists can do and how they can build consulting businesses that really add a lot of value to their patients. So the next steps that I want to talk about for pharmacists who are watching and who are thinking, this sounds great. How do I get started? How can I start a consulting business like this? So the first step I always tell people is, no matter what you're planning on doing, start relationships with your providers in your area. Start some in-person meetings, start sharing with them about your services, even co-hosting some networking events, and start supporting their patients. It's going to help give you an idea of what their goals are quality-wise and patient outcomes-wise, and also what their pain points are. So I spoke briefly about understanding quality measures, and there's a lot more information in the Academy about physician quality measures and how MACRA has really transitioned the fee-for-payment model to the pay-for-performance model. So really looking at what the physician's quality measures are and whether or not they're being meeting them and getting incentives and additional payments, or they are being penalized for negative payments. So that would be the next step. So I want to ask you this. How many of you guys have ever said this? I'm not good at selling myself. Well, as an entrepreneur, one thing I always say is you are talking about your strengths and you are trying to provide value above all else. So when you go talk to the physicians, you're not just pitching your services. You are starting a conversation and a relationship with that provider or with that pharmacy you want to work with, or even with the patient. And you're trying to share your unique values, but you're also trying to figure out what their pain points and what their goals are, and really what it is that is holding them back from achieving those. So your homework after this webinar is really to evaluate your options for consulting. So think about some of the consulting options that we've talked about here today and determine who your target market is. So maybe you're interested in working with physicians under a collaborative agreement and also billing for services to private payers through the association. So determine what value you can bring to these patients or these providers and start relationships with them. I cannot stress that enough. So if you want a little bit of review on the consulting options, there's information in my book, which is available on Amazon, How to Build a Pharmacy Consulting Business. And it's really going to talk about the basics of billing for pharmacist services and even give you a few tips on how to put together a short elevator pitch and how to go in and market your services in a way that feels very natural and feels much more like education and can make you feel more comfortable in having those conversations. And if you're interested in joining the association, you can go to aprxs.org/membership. Using my special member code, the Pharm Academy 2017, you can get 20% off your monthly membership. So this is what it'll look like when you join as a standard member for pharmacists. Normally, this is $100 a month without a long-term commitment. But if you join using my code Pharm Academy 2017, you can join at a monthly rate of $80 per month. So I'd be happy to answer any questions now if you have any questions, or if Noah, you've gotten any questions in advance through the email.
Yeah, we do. We had a few questions. One of the ones that I've wondered about for a while that came up is, as you're out there developing these community relationships, how do you broach the subject of the collaborative agreement with a physician? Are they familiar with it? Do they understand the value to their practice? You mentioned MACRA. I mean, what is that? Is there anything that you guys provide at the Pharmapreneur Academy that can help people understand how to present that value to the physicians in their community?
Absolutely. So we have over 9 hours, I believe, worth of video on how to offer your services, how to structure your pitch, how to create presentations or even marketing flyers that make you feel confident in going in and talking about your services. We talk at length about the physician quality reporting system, which is now known as MIPS under MACRA, the merit-based incentive payment system. So we talk at length about what those quality measures are and how pharmacists can structure their collaborative agreement and their services to focus specifically on those patients. So say, for example, a physician has quality measures and their benchmark is all diabetics on an A1C less than 7. So they're being graded on those benchmarks. So you're going to offer pharmacist services that are in alignment with helping them achieve those outcomes for those patients. So there are plenty of physicians out there that don't fully understand these changes that have occurred. And like I said, changes in the pay for performance model where they're being penalized or incentivized. This is something very, very new, and it's something that pharmacists may even have to explain a little bit to the physicians. It may be something they've heard of, but the lessons in the academy really give you the knowledge to go and talk about these services, and also to structure a collaborative practice agreement in a way that is legal and that is, still open and flexible and can really make both parties in the agreement feel comfortable with moving forward with these types of services. So I'm very excited about the information that's in the e-course at the Academy.
Yeah, it's fantastic. And obviously we're very proud to partner with the Pharmapreneur Academy because pharmacists promoting their value has not been a traditional concept. And yet the physician community in general, just they are so poorly educated about what the effects of these value-based or the performance-based reimbursements are going to be, that someone really needs to come in there and not just tell them, but also give them the solution that's going to help, either prevent their own practice from losing money or help it, become more profitable. So I think it's a fantastic service that a pharmacist can perform, and the physicians easily see value when it's explained to them the right way. So I think you're on the right track. One of the other questions we have that comes up frequently with us at the association is, can I get direct payment through Medicare? And I'll answer that one really quickly, and then Blair, if you don't mind filling in some of the detail. But the short answer is no. You're going to, the current process of applying for a PTAN can be very frustrating for a pharmacist. There's no direct denial of that you cannot ever get a PTAN and therefore will not be paid directly by Medicare. But it can be a very frustrating system, and I don't advocate for it being the primary focus. If this is what you're trying to do, I don't think anyone should try to go about it as being a direct reimbursement through Medicare model. However, we do have members who have secured contracts with Medicare Advantage plans, Medigap, and again, our focus is the more that a provider asks to be included in the process, the more that the payers are inclined to make it happen. And a good example, and I always use this, is if you call United Healthcare's provider sign-up line, they have 2 prompts. The first one is for physicians, the second one is for chiropractors. The only reason that second prompt exists is because a lot of chiropractors wanted to contract. And we believe it's going to be the same way for pharmacists, and that's what I think we've shown through some of our programs and continue to want to show people. But the primary focus of working with Medicare patients for the time being is really going to have to be a collaborative agreement. And I'll leave it up to Dr. Thielemeir to endorse or change that, but that's been our feeling here.
Yeah, I agree with that. I think that this is kind of a triad of tools in your toolkit, so to speak. So in the community pharmacy, we're billing for MTM services, but it's through Medicare Part D. In the physician's office, if we're billing for MTM services or chronic care management services through the physician, it's going to be Medicare B. If we're billing through private payers, we're going to use the association. So what I see is a triad of these three opportunities working together to offer pharmacist clinical services in a way that offers value to the patient and also provides return on investment for the pharmacist's time and for the quality and services that we offer. So I would definitely agree with that if you're going to be offering services through Medicare D, it will have to be through a community pharmacy, and to Medicare B patients, it would have to be through a collaborative practice agreement. Most times under the direct supervision of a physician, but in some cases, such as chronic care management and transitional care management billing opportunities, those can be done without the direct supervision of the physician. Therefore, it means that they could be done by off-site consultants. So it's very technical. There's a lot of information. I've done a lot of research on how consultant pharmacists can offer these types of services in an off-site consulting model, and all of that is located within the e-course at the Academy. And I'd be happy to answer any more questions if anyone has about those types of billing models, if they'd like to email me after the webinar.
Well, fantastic. Dr. Thielemeir, thank you very much for joining us today and taking the time to talk to our membership, and we look forward to doing this again in the near future.
Thank you so much.
All right, everybody. Thanks for joining.